We want to start with a call to order and recognize a quorum.
I do believe we have one. Right. I'm here.
Is Crystal Smith online?
I am.
Thank you, Crystal.
So she sent out the meeting minutes last week from the November 16th meeting that we had. So we need to approve those. Everybody have a chance to look over those. Motion approved. Second. Second. All in favor? Any nays? Thank you. Are there any new members that are here for the first time or on the line for the first time to this meeting? If so, we would like to recognize them, please. What's your name?
Rebecca Harkness from Stevens County.
Welcome.
Thank you.
Formerly from Philadelphia.
Yes. Who knows your?
Don't tell all my secrets.
Nikki Fairclough, AU Health and Intervention.
Marianne Nolan, AU Health Director of Emergencies and Critical Care Services.
Is anyone on the line that's new? Would like to introduce themselves?
We do have our, is this the right time for me to introduce our new Stop the Bleed coordinator?
Yes.
Okay, Craig Nickel. Craig, stand up so everybody can see your face because I wanted y'all to get a good visual. Today is day one for him as our contracted coordinator to really support. You were not at the commission meeting earlier. The Stop the Bleed champion for Georgia named to the ACSCOT is Crystal Smith. So I think now we have like a power duo between Greg and Greg was, and you guys are pretty close. You're making,
We're
right?
about 2 miles.
Oh my God, it's more dangerous. I'm not sure. But anyway, I know all of you are very active in your Stop the Bleed programs in your region. So this is going to be a huge boost to the program, and with our new planned rollout of education and kit distribution, it will really help. So thanks, Greg. Welcome.
Happy to be here.
Yeah, great. Contact information, check. We'll do. We're working on a business card. Okay, this GTC update. Hey. I think everybody was here for the morning meeting. Yes, I don't want to repeat all that information. Okay. Just briefly, first of all, thank you for everybody for coming and supporting, and we hope you liked it. We're trying to work out somewhat of a more predictable pattern for our meetings, so that you're not always, where am I going, what am I doing, and maximizing our time together. As much as I think like these meetings are too expensive and we shouldn't do it, and everybody says how valuable it is to get together. So I think the commission, and luckily Regina is the treasurer, so she hears you loud and clear. So it is a priority. We want to make sure folks get together, but we do want to make it reasonable so it's not cost prohibitive to get here. So stand by, more information coming soon on that. Cheryl and I are actually going to meet with the Chateau folks to talk about options potentially for next year. So we get a little bit ahead of the curve. The commission did approve a reallocation plan for some leftover funds from the FY23 budget, as well as our annual firework revenue fund distribution, which was just under 1.5 million. So many of you heard over the last day or at the GQIP meeting that we're going to continue the work to become, for GQIP to become a PSO. So that was a portion of that will support that. And then the remainder, most of the remainder will be split between the trauma centers and EMS. And then the level 3s were increasing the funding by $75,000, the 4s by $25,000, and then we will, the budget committee, Regina is working closely with them to come up with a plan for 2024 so that we can be all inclusive with the funding. Because you all play a very important role. We don't want anybody left out of the funding. It is a little hard to plan for some of these things though. And then the biggest thing is with the new model with ESO, the way they charge for the registry, you're now charged, as you all well know, I don't have to tell you, but by your bed size. And so the money that we give you for 3s and 4s to support your registry falls well short of what it actually costs you. So we're matching those funds. We're working closely with ESO to make sure we know how much it costs. It's different for everybody. We just want to make sure you have that, that money to support it. So we're working again on the 24 budget. So much more to come. We have to create several different scenarios, and I don't know how we're gonna, we need to find a money tree. I don't have one right now. So, and we did have some discussions about how do we go about asking for more money. We're very exciting at the commission meeting. We had the startup of a rehab group. Dr. Kornbach from Shepherd Center is leading that up. And at some point, that's going to translate into money as well. So definitely need more money. The ACS visit and the PTSF level 4 visits, much more to come on that. We know we need to do a lot of planning once we get our final report back from the ACS. And great presentation by Dr. Proc this morning. I believe it's already uploaded. Gabby's so quick on the draw. The presentation that he did, we probably need to put a group together to kind of tweak some of that, because that's a rich data set of what he has. So there's lots of things that you guys might need regionally sort of pulled out from that, and I think we can do that. So we just need to know what additional information that we need. Also, we did actually lose a level 3 below you and a level 4 in Maxley after that, because that only went up to 2020 data, at which point they were still level 3 and level 4. So access is definitely impacted in that area that we know is already vulnerable.
I think there were a couple of trauma center names that were incorrect, or put in the incorrect regions.
Yeah, he was going by the number that they were assigned and try, because he didn't get that information this go around. So he tried to assimilate using the previous first decade. We need to do this more than every decade, but with the ICD 9 to 10 transition, that's what sort of hung this one up. So I think that's about it, really, unless anybody has questions.
Okay, thank you, Liz. Marie, do you have a report?
Are you talking about for the Office of EMS and Trauma GCTE?
I am.
Okay.
If you'll come up and speak to one of the owls, the gray owls, or at one of the microphones.
Okay. Is this good? Yeah. Well, as you know, with Renee leaving, we'll have April Moss to do the trauma program manager review part of the OTCPE online. And the next one that will be due is April 15th. We will be reviewing the OTCPE form and the burn form as well. So if you have suggestions for changes for next year, please let us know. We'll be working on revising the OTCPE form and the burn form over the summer. Is there anything else you were looking for besides that?
No, you said the due date for the next
Is April 15th.
15th. Okay.
The form will open March 15th. And it will close 10 days after the 15th. So we're giving you 10 days grace period. But the due date is 15th.
And April, will you stand up so everybody can see your sweet shining face?
I want to
Say hello.
introduce her. April Moss is our Deputy Director of the Office of EMS's System of Care Program, which oversees trauma, stroke, cardiac, EMSC. Welcome.
She still has that new car. So,
Yeah.
Michael, so is Kelly, are you reporting for Michael, or is there anything else from the office?
I'm not real sure what Kim or David would normally report on. Is there specific?
No, you're usually just, it's an agenda item, so.
We can get with them offline.
Okay.
Yeah,
All right.
we'll develop your report for what it'll look like moving forward.
Cheryl does not, you don't really have anything to report, do you? Okay, thank you. Gina?
Say it here, or so the outline here. I know, thank all of y'all for attending the GQuip meeting. I thought it was a great day and we're already planning the summer meeting. So you will be getting emails from me, but really, since most of y'all are there, I don't have a whole lot to add, except for the Arbormetrics login. I do have a few centers who have not sent me their folks that they want to have ability to log into the Arbormetrics platform. So I'll be following up with that. And I know all of y'all have gotten the update to your V5. And Kelly may speak to that a little bit more for your center. So there are some new things, probably some challenges we will be talking about and some definitions, and which will be helpful moving forward with our data. I also shared, we'll be sharing the data completeness scorecards that I spoke about yesterday with the trauma program managers, and they can share with their other staff. And these are not, number one, they're not punitive, and I am not perfect with the registry. So I look forward to if you have any feedback or something doesn't look right, or you run the same data from your facility and you're like, this doesn't make sense. I am by no means an expert. So please shoot me an email and say, hey, this may have been missing for this reason, or mine look different because I do X, Y, and Z. And I also may send some questions to folks who had some oddities or things that looked a little bit different than how other folks captured it. Just asking some questions on that. So I look forward to what we have moving forward with that with Arbormetrics. It looks like a September kickoff. We're still doing some work with that. And we will be doing time to definitive care and hip fracture within 48 hours will be the first two metrics that will go live, and they will build the other metrics we developed over time after those. So happy to take any questions.
When do you anticipate us starting to do something with the data? You're just, I understand you're just getting through and kind of looking at everything.
The raw data or the Arbormetrics data?
Arbormetrics.
Arbormetrics. So we will probably start having some testing ground, they hope maybe around August. They actually have test files already. So that was one of the big things that they had to have. So they have everybody's calendar year 21 data in a test file. So they are looking at the data now, seeing what they have and how they need to build those analytics with the data that's in there. So that's where making sure a lot of these things are on the same page may not impact these first few analytics that we're going to do, but moving forward, we want to make sure that everybody is putting in apples to apples. So when we run those reports that we get the analytics back that we need. So.
And I want to say, I appreciate all the work up front. That sounds like a minor thing where you can start displaying the data, but Gina had to go through and complete a dictionary. So if she said, I want to look at X, Y, and Z, she had to say, this is the numerator, this is the denominator, this is where you pull it from. I mean, it was very detailed. So it took a lot of work up front, and I appreciate that.
It did. And even though time to definitive care and hip fracture sounds just like two buckets, and it is, there's actually probably about 50 analytics that's within those two buckets. So they are there's a lot behind the scene that goes on to give us those two metrics. So it's much bigger than that. And mortality and major events will be included in that as well. So those are just the two process, and then mortality and major events. So, but it's exciting. So I can't wait for us, all of us, to be able to see exactly what we're going to be able to get out of it.
Thank you. So moving right along to our subcommittee reports, education, Kim.
Hello, thank you. And before I start, I think it would be always really important just for me to acknowledge and just appreciate all of the work that Jessica has done as the chair of the education subcommittee for the last 2 years. She's done a great job, and she's made it very easy for me to step into this role. So thank you, Jessica. And on behalf of the team, we are very grateful for the work that you've done. So thank you. Just to update everybody, we had 2 new projects that we're working on for this last year. We were trying to do some outreach and education to the centers, to rural centers, especially if they're referring, to try and help get some understanding and information about the things that were causing delays in time to transfer to care. So we put together an educational offering that we would like to be able to send to the centers that accept patients, that they're able to then share with their partners that do tend to send a lot of patients to them. Just 8 or 9 PowerPoint slides, just going over why it's so important to try and minimize the delay in transfer and how that impacts the patient's overall outcome. So we've got that complete. We have tried to format for an education subcommittee PowerPoint slide that looks a little more official, PowerPoint template that so that we look like we're coming from, a part of the GCTE that's just looks a little more polished. So we have that. Go ahead and I've sent the original PowerPoint to some of the key voices in the team, but I will send it again to the keys just to get your input, your feedback, and your thoughts, and then we will, after that, we'll then probably sending that to the level 1 and level 2 centers. The next thing that we've been looking at
Is the education geared to level 1 and 2 centers, or also 3s and 4s, or?
The intent, I think, was to, for the level 1 and level 2s that are receiving the patients, to then be able to use it as outreach to their level 3s, level 4s, non-trauma centers, and even their EMS partners in the region to help them to understand why appropriate triage and minimizing the time to arrival of defendant care somewhere.
Okay, and maybe we can talk about this offline. I'm just thinking it might be quicker to get it to everybody, but we'll look at that and discuss it and decide.
Yeah, some of the information, there's options or opportunities for the level 1s, level 2s to have data specific to their center about, or specific to a hospital that they're going to be speaking with about their average time to transfer that we can put in there and give that detailed information.
Okay, and does this PowerPoint have like a voiceover?
It does not, that's actually a good thought.
Okay.
Speaking of Kendra, I just happened to have see it this week. So if you want to do a little micro beta group and subscribe to the audience, you're welcome to. Not forget.
Crystal, you're breaking up on the line.
Okay, I'll call the phone line then. Sorry.
Okay.
So while we're waiting for Crystal to come on, we're doing a similar project with the acute kidney injury, trying to address that. The PowerPoint presentation for that is nearly complete. We're online, on track to meet the deadline that we have for that. And that will go through the same process. That will go internally to the education subcommittee, just for review and input, and then we'll send it out to the teammates just for review and input before it goes out for dissemination. And then just a final update, we were able to use some funds last year to purchase the TCRN review study guides for trauma centers and throughout the state. So those have been mailed out. If there is somebody who thinks they should have received their TCRN study guide and did not, please reach out to me. I have a couple of extras in my office, and I just want to make sure that I got everybody. So please definitely reach out to me. So we're very excited about that. We're actually planning to track the TCRN certification rate in the state, and the hope is that we're going to help push the needle forward a little bit in terms of the number of our certified nurses with trauma. So, and And then, as far as my transition into this role, we have somebody who has expressed interest in stepping into the vice chair role, so I'm very excited about that. We'll be voting on that at our next education subcommittee. So, thank you.
Thank you, Kendra. And just as a aside, or just to let everybody know, we're really emphasizing that all the committees have co-chairs or vice chairs, so that there's somebody there to step up into the role. While we've got a lot of talent here, we want to always be developing talent also, you know, as far as and participation in the different committees. So I appreciate that. So next we have Kelly from the pediatric.
Good afternoon. The first project that is kind of an ongoing project is the SIPA project, and that's the Shock Index Pediatric Adjusted Score that we're going to try to do some education in the state to use it as sort of a fifth vital sign in hopes of protecting pediatric patients from being put in the back of the ambulance and transferred long distances and not be stable. We were trying to get some of that education together, and then Dr. Slidell came out with the pediatric shock index, which is, we're thinking, a little bit better tool. Instead of being based on age ranges, it's based on single age, but the specific physiologic signs that a child that age would have. So it's a little more specific.
So the SIPA score is basically the pediatric version of a shock index.
Yes,
Okay.
yeah. But there's a better, the pediatric shock index is a different tool. And we're thinking better than the SIPA.
Gotcha.
So Dr. Smith has done a couple of talks around the state on SIPA. But I think the talk that she's going to be doing in March in Macon is going to be the first one that she's going to incorporate the pediatric shock index. And so we'll be able to, you know, study them both, and we're plugging both indexes on our highest level of activations at SHOA, just so that we can get some better data. So more to come on that. In coordination with the education subcommittee, who's looking at time to transfers, the PED subcommittee is looking at pediatric transfer rationale. And at our last meeting, I agreed to pull some data from CHOA, and it was pretty impressive. So at CHOA in 2022, there were 1,680 trauma patient transfers to us, and 578 of these patients were discharged from the emergency department. So that equals about 34%. So there's a lot of work, I think, that needs to be done. We're doing further drill downs to see what the percentage of mild TBI versus orthopedic injury, those types of specific injuries that sometimes get to go home from the emergency department. But a lot of these transfers in were, greater than 1 hour away. So that's just a lot on parents and families. So we're hoping that this project will bring some enough validity to warrant investigating a Georgia pediatric virtual program. I know that's been a big hot topic in Pediatric Trauma Society and a lot of the bigger physician conferences around the country this past year.
So you're talking virtual consults?
Yes, yes.
Or ED patients. That would really be helpful because you could cut out a lot of transfers that way.
Yes. I know in the past, the biggest problem was with billing, which is why no programs ever really got off the ground. You know, we have a whole great big room at CHOA with computers and everything in there for virtual medicine, and it sits in because I don't think they could ever get the billing piece down. Utah, University of Utah has the program figured out, and they actually support the entire state of Montana because Montana, everything's so spread out. So they have a huge virtual program. And definitely taken the lead on virtual medicine. So I think think Dr. Smith has some appointments to set up to speak to them and ask them some more questions and but I think that would be the program to follow. We're gonna get to that point.
And we'll hear more about what Utah's doing when we talk about organ donation, because they're actually doing brain death exams virtually in Utah also.
Yeah, it's a pretty amazing program. I think there was a talk at, remember, it might have been Pediatric Trauma Society. Kendra, was that talk at PTS? So there is, somebody did a podium presentation on that program, so it is available. Pediatric Trauma Society, the last year's meeting, if anybody wants to Google it. And then we're having meetings, I think Joe is about to start a study using whole blood, so that'll be interesting for the state too. You know, we're always a guinea pig, but it's a multi-center, it's a national study. I'm sure that it's being run by Pittsburgh. But I think we're about to embark on that. So. And we're continuing to try to work closely with the PEDS Ready Committee to assist in pediatric readiness on the state for that role.
And I was asked for a contact. I gave him Crystal's name. I blanked out on your name, but from Mercer University Center for Rural Health and Support, I think they're interested in helping, looking at pediatric readiness and some of this pediatric consult program. And I meant to mention that to you earlier and I forgot. But one of the statisticians, biostatisticians, is looking to get involved in that.
Nice. Thanks.
So who do we have next? So John?
Good morning. The PI subcommittee report is a little interesting. We kind of gone around in circles a few times. What we have done is we do have vice chairs in place. And we divided up this as far as how we were going to work on it. Raymond took kind of lead on trying to follow some AKI issues. And I was following up with some other centers on time of defendant care. What we run into most of the year that we've noticed is we will get so far into a certain issue, either what we're working on is either already been done or is already being done, or such as sitting next to me or response committee, that's where we actually need the information from, and that's something we're doing anyway. So with that being said, and with the dial in with the AKI look, we're looking at completely restarting over as far as the initiatives we're following, and the talk is to focus more on time of definitive care, but more on specific data points. I don't have the answer as to how that looks yet, but that is more of the move forward. So we've been working, but for us to get something that we really want to show off yet, we've got anything we want to show off just yet. Speaking of stepping forward and stepping around, and this is just an opportunity since we're all in the room, I had a lunch conversation with Karen Cuss, who's sitting over there. I'm pointing her out right now. Karen's been working a lot on as far as time and transfer, and because of the size of her center, I think she could bring a lot to this, and so we've had a good conversation around her taking some of that initiative and possibly putting that into the PI committee, because that will give you something to dial in, and then we could possibly bridge that between the 3s and 4s and 1s and 2s. A lot of my work revolves around the 3 and 4 committees. And of course, I've been pretty heavily involved in the EMS branch overs. So we feel like it's a good move, and good growth, that if everybody lets her in, which I'm pretty sure not going to be too much trouble, Karen's going to take my place as the vice chair of the PI. And so we can concentrate on what we're actually working on. So, and that's the big catch up there.
Okay, and I did want to recognize Rama and all the work that she's done so far. Things did get kind of stalled because of the way the Trauma Commission wanted to change, but writing the report for AKI and working on that, So you guys have tried to do some things, but we just haven't been able to pull it all together. So I just want to recognize that. Thank you. So you will be stepping down as PI co-chair and Karen will be taking your place.
That's correct, and to be clear, I'm all for all participating projects or whatever, but look here, it ended up.
Okay.
And the other thing is, on that note, Jess, we got her into it about 4 times. So we need to make sure we put her on there too. Because when we got into AKI and of course the bridge over Mark Benton projects, we pulled you in and then we also somehow ended up making her do monkey surveys and about 4 other things. So recognize the fact that we've been dragging her around with us also.
Okay, thank you. And before Kelly starts with registry, I do want to mention that a level 3 and 4 group, that's somewhat of a mentorship coalition of the program managers, PI people that work the registry. They're working together, but they really report through that GTC meeting group that Dr. Patterson, thank you. I was going to say Dr. Kelly. Dr. Patterson leads, they report in, and they've got 2 big initiatives this year as far as working on PI plans, having working real existing PI plans, and then also making sure that they have the outcome or the PI registry portion of their software and that they begin to use it. That was a big weakness that the Pennsylvania group found. They wanted to see more of that done within the registry attached to certain records. And so in talking with different people, we realized some of the centers have been allocated money for that, but it had not gone through and come back around to where they have that piece of software or that part of the registry. So that's something that the group's working on, but they will not be really reporting as a group to GCTE. They're going to report through that level 3 and 4. Thank you. So Kelly?
Okay, so the registry subcommittee has had quite a bit going on. Before I get into our official report, I do want to say something while it's on my brain. The ESO files for the 2023 updates went out last week. Is Mo in here? Where is she? Where?
She no more.
She knows. So, Mo, actually brought up my attention because I have not downloaded those to our registry yet, but there are several new data fields. So if you see these data fields, Gina and I took a look at it yesterday afternoon for a little bit. It seems these are NTDS fields, and we need to investigate those a little further. Mo has said that this does not impact your closure of your records, but they are there. The other thing that there is a glitch that ESO, they talked to ESO while they were here, there is a glitch. She said the 15-year-olds are trying to close a 15-year-old's chart. And if anybody who repeats knows more about this, please speak up. Do you know?
Kelly has screenshots.
Yes.
It has to do with, has to do with comorbids. And it wants us to answer NA. So it's giving us an error message, but NA is not an option.
So ESO is aware of that and is working on a patch. So keep that in mind if you're trying to do your registry for 2023 records. I think that's the stuff that's not on my report, but I needed to talk about.
So with the ESO new data fields that are showing up, right now, we do not have to complete them.
Correct.
And we should be able to close without them, because we really, if they're in the data dictionary, we could fill them out.
We
But-
could.
And I wish Mo was here, because she's looked at it a lot. There is one, only one of them is an NTDB field, and that is the primary service, and that's the peds or adult service. That is a blue field, so you're going to have to put something in that.
A peds or adult,
Right,
okay.
service. If you look at, with your update, you got a change log on there, and you'll see how many things are
on that list. A lot of it has to do with the gray book changes, if you read it, and some things with the ITDX, which is the International Trauma Data Standard.
Mhm.
So there are some new fields that show up, but just remember, if it is white, that's not an NTDB field. So there's only one blue field, if I understand correctly from Mo. And that's the service. And the reason they did that, and where's Kendra? Kendra is those centers that do adults and peds, they're having to delineate like what bucket that they go in. So most centers here are gonna be a default to adult service. You don't have a pediatric trauma service. But Kendra, they will have to go in, some of them will be adult trauma service, some of them will be pediatric trauma service. But like Kelly and Mo will be all ped trauma service, because that's all they do. So most of us will probably be able to default that, but that is a blue field, that is a new NTDB field requirement.
So for my center, we are not peds designated, but we're an adult center treating pediatrics.
Then you don't have a pediatric trauma service, is my understanding when you look at the data dictionary
Okay.
on that. So, but that may be something we need to talk about a little bit more. But there are a lot of new extra fields, like a regional trauma number,
Yes.
like there's.
That they added incident number under
Yeah.
EMS, so if you have multiple ambulances that respond to maybe 6 or 8 people, but it'll be one incident.
Mhm.
You can tie that in, and I think Mo's on the call. I don't know, Mo, if you can unmute and share anything that we have not already said.
Can you hear me okay?
Yes.
Okay, sorry, I'm here. I couldn't unmute fast enough. You're correct. Those are the fields that they were talking about. And then ESO, we contacted them and they said that they were aware of the problem with, I think it's either 14-year-old or 15-year-olds falling into that age bucket with the new codes that we need to put in on them. And they said that they're going to have to come out with a patch for that. So more to come on that.
Mo, are you good if we share your cheat sheet with everybody that you created?
Yeah, that would be fine.
So Mo did some screenshots of the new registry fields and kind of highlighted them as like a tool for her registrars, and it's great because you can see exactly where it is. And but remember, if it's a blue field, then you're going to have to do it. The white ones we can discuss later on and see how we're going to address those. There's some new options and outcomes, like is it a TBI rehab that they're going to? So there's a lot of questions I think that we need to answer, but some of the stuff can be really useful. And a lot of the information that it says in the changes are related to requirements out of the gray book. So my guess is there are things that you're going to have to speak to when you have a verification visit under the gray book that you didn't have to in the orange book. So they're trying to give us a way to capture those. And since that goes live in what, June?
September. When we start.
Yeah. So,
so what I have these changes, so what I will do is share this with I can share it with you to share it out, or do you want me to send it to the registry group? Or what do you want me to do? Send it to everybody. I'll just send it to everybody.
And I think we definitely need to, and this addresses something in your report, for the data dictionary group, that they need to know about this. My question would be to ESO, how, was this announced that they were gonna have these data fields? I know that it helps us with that, but they show up and they have no definition, and then we don't know what to do with it. So we're kind of surprised at this. So since we're not really an ESO state per se, because our central registry is image trend, I don't know where that conversation takes place.
Yeah, and I think that since they're ITDX fields, it was, ESO didn't pick to put them in there.
Gotcha.
It's
Gotcha.
a global,
Okay.
international data field that they're trying to capture that they added.
Okay.
And they just made a note that some of the new fields are created to meet the gray book standards.
Right.
So,
Right. I think maybe going forward, we'll try to improve our communication, so we'll know ahead of time and be a little more prepared. Because, you know, I'm all for being prepared for a survey, as I'm facing that right now, and it helps when you're running those reports, but you don't know that they're showing up and even how to use them, because we're not even truly into the gray standards yet, or the 22 standards. And so that's a little unsettling, but, Kelly.
Okay. So the other, now the official report, we were, the registry was looking at the transfer to definitive care. We've been looking at that with Gina, pulling data, working with the PI subcommittee. One thing that I'm interested in on your PowerPoint, once it's released, we've talked a lot, John and I had a sidebar yesterday on the feedback report, whether it be the feedback report from 1s and 2s to the 3s and 4s, or ensuring that the 1s and 2s get the information from the 3s and 4s that you need for your registry. So I think moving forward, the registry subcommittee will look at what we need to make sure the 1s and 2s get, to complete your referring hospital field, all your information that you need in the registry. How can we submit that or send that forward to the right person, the right registrar of the 1 and 2, and then the PI person or the trauma program manager in 3 and 4, who do they contact, and then somehow have a template report to send back to the 3 and 4.
Okay, if we could talk about this, because I had another conversation with somebody else, that this might be done electronically without having to go through the registry, which would be a little more efficient. So let's talk about that. Okay, at a future date.
All right. The second thing, we did talk about the ACA standards and the data management plan. From a registry subcommittee perspective, there is a draft plan that has been shared with the GCTE leadership group and the registry leadership group. It's not quite ready for send out to everyone. One thing I mentioned this yesterday when John and Tracy and I did the PI presentation for the 3s and 4s. We in our center have ended up titling our performance improvement plan, the performance improvement and data management plan. Because if you look in topic, all of the chapters or table of contents includes the things that the data management plan was supposed to come in anyway. And so we as an organization just incorporate all of that into ours. But once we get feedback here from this group, I actually did send it to Karen too, because Karen and I are both going to be visited in September. So once we can get some feedback there, then we can send it out as a template or an option for anyone else that may want to use it moving forward. So that's where we are on that. Now, the next thing is the registry educational requirements. This is another grade book standard that mandates that trauma center staff have certain courses. So I don't know if you attended the trauma commission meeting this morning, but Tracy talked about that, had an ask for the commission that we get funding specifically for education for registrars or for those that collect data for the registry. And the idea is that we allocate X amount of dollars to different vendors, whether it's ATS or AAA, but it's securing spots. And from that perspective, then people can sign up for the courses. That, I think, is going to be the better solution or process from a commission perspective to keep them from having to monitor compliance quite so much. They can just contract with the vendor for X spots. We're looking at AIS and ICD-10 courses, we're looking at trauma registrar courses. I talked with Liz a little bit about the real topic, and I think that's coming, but I'm not sure that we'll do that this round. So there will be priorities for the level 3 and level 4 staff. I know that 1s and 2s have multiple registrars in their organization, and just so that everybody gets a fair shake at the money or the funding, we've talked about putting some priority on those lower centers. let's see, the other, we've got actually 3 more things. The AIS 2015 conversion. So that is something that is up for discussion as well. We're just talking about it right now because anyone who has done any type of transition or conversion in an electronic medical record or an electronic system understands this is a multi-year process. So we're trying to determine, do we set this as a 2-year goal? Do we set this as a 3-year goal? You know, what year do we want to start using AIS 2015? So stay tuned on that one. The Georgia Data Dictionary, we have talked about putting a few committee members together and revising the Georgia Data Dictionary on an annual basis. I don't know, is Colleen on the line? I didn't see you sitting there. I know that she's been instrumental in reading, reviewing, talking to me about things and, working with, trying to get this up and out. I don't know if you have anything, or Marie, if you have anything to share on that. Not really for now. I do know these ITVX fields, we probably need to look at that and how that compares to Georgia, what Georgia has on their data dictionary.
It's probably a really good thing we have that done, because we just have to start the work over again.
Right.
So,
Right. And the only other thing that we had is, there are some registrars who want to do an in-person meeting. And so we're trying to determine how we can bring the registrars to an in-person meeting to coincide with the GCTE meeting, just to allow us time to get together, network, and talk. So,
I think if possible, long-term, have a half-a-day meeting where we could get continuing ed credits. Because we do offer that with the GCTE registry subcommittee. And as a reminder, that does usually award at least one continuing ed credit, and that you have to fill out your evaluation forms within a certain time frame and get that certificate, and that's administered through GMA. And the commission helps pay for that. So that is one way that your registrars can get their continuing education. We wanted to offer some more as we can. And it's open to any discipline, those credits would count. Now, whether it applies to your certifications or not, that's something for you to say, but it would count toward your trauma standard required continuing education for registrars.
So the only other thing, we were looking at 25 slots for this education for these courses, 25 slots in the AIS code course and 25 for ICD-10 for the 2024 state fiscal year. Those would both be virtual. So I think today in the commission meeting, Regina said, just get her the plan. So I will do that and we will go from there. That's it.
Thank you. Crystal?
Good afternoon, everybody. I'm not sure how the sound is coming across there. We're getting a little bit of a echo.
You sound fine.
Sound okay? Okay, good. Just wanted to first and foremost tell our Burn Center partners that congratulations on a great symposium. If the folks in the room would just give them a hand, because it was really great as well. I know the GQIP meetings were also very, very, very positive, a lot of things, but just want to thank the Burn Center folks for doing just such an excellent job with their symposium. A couple things, a little bit of a shameless plug. Some of y'all have already registered, and it says my screen share is loaded. Are y'all seeing my screen right now?
No, it just says Crystal Smith has started screen sharing.
No.
All right, we're maybe. It's kind of frozen, but nonetheless, just wanted to tell everybody again, thank you for all that you continue to do to keep all the various programs up and going. We are continuing to work and do some of our trauma awareness webinars, and just appreciate all of y'all for putting those forward and making sure that your folks are notified so that they can attend. My sound still good on your end, Tracy?
Yes.
Okay.
Yes.
And I do apologize. Again, it was just a little bit of feedback on my end. But thank y'all. Bingo size is going great. If anyone is interested in joining the Bingo size family that may be not participating currently, I do want to just give a shout out to Sharon Grayson, who is in the Zoom room today. She's actually fixing to start a multi-county cohort with some of our Central Georgia counties and some of her metro senior centers. And Sharon is a great mentor for anybody wanting to start bingo size and just get a bird's eye view into what's going on in those courses without necessarily having to travel. That's a good program for that. If you're leaning more towards in-person, it's still a great introduction to be a part of some of the stuff that Sharon and Nicole are going to have going on in the next couple months. I think our regional team is actually going to kind of try and flank her folks by actually maybe making some in-person appearances at those various centers to just kind of be cheerleaders for the program as she is working with them in the virtual world. With that being said, if you're got your heart set on in-person offerings, we've got several going on all over the state. I would say so far, the folks that have done the most in-person offerings in our trauma family is going to be the folks up at Kennestone. So talk to Julie and Danielle if you're interested in maybe shadowing some in-person stuff. But I believe our friends at Grady are working on some in-person offerings too, and they've actually expanded the program into some domains that we have not presently been into. So I think they're doing some more nursing home setting, bingo size, and some assisted living stuff. So if you're interested in those types of offerings and just want to see it so that you can kind of understand it before you say, oh yeah, that's something I want to do. Those are the folks that are going to be best reached out to. And bingo size, again, is our big fall prevention offering. We're still looking to do a number of other things in the coming months. Of course, Child Abuse Prevention Month is going to come up in April, and so be looking out for some webinar announcements on that. And also, of course, Trauma Awareness Month is going to be in May, and so we hope to put out some resources that all of us can use for Trauma Awareness Month. Again, I'm not really sure why my screen is not sharing, and I apologize because that's usually what keeps me on track. But just know that we're got a lot of stuff going on. Be prepared for resources also for Georgia Stay Safe Week. Usually that's going to be the first week of the summer. Those materials are still available at georgiastaysafe.org. We hope to be transitioning that website away from the Region 5 website, but it's a standalone resource center. But Tracy mentioned in the Georgia Trauma Commission meeting today that we discussed at our last meeting developing a framework for perhaps letting us know what your injury prevention funding ideas may be so that we can pass that information along to the Georgia Trauma Commission. So I do need to follow up with Liz and her team on that just to make sure that is their direction she wants us to head into. And then I think my screen is finally sharing all of a sudden, though it's not necessarily sharing what I intended to share. It's still a very cool picture. So do know that our pediatric symposium is coming up next month. The EMS for Children over in Region 6 is also going to be hosting a pediatric symposium in May. I did want to tell my trauma family in the room, several of y'all have indicated that you like our Prevent Trauma Llama t-shirt that was actually designed by one of our Region 5 folks. This is not clip art, guys. This was lovingly drawn by somebody in the trauma family. And so if you're looking at those EKGs there and going, you know, those are not true QRS complexes, that's not their intent to be QRS complexes. They're FLBs for those folks that are in the room and would judge us. So a little bit of, y'all can have a little bit of medic humor. We are doing our shirts for our Pediatric Trauma Symposium in royal blue and black because that's kind of our trauma RTAC colors. But I will tell you that we've actually discussed with the t-shirt vendors if any of the other centers would like to do t-shirts in the future, they will honor our pricing if that's something you're interested in. So you could have the atrium green. I think Lynn and we're going to do something for St. Patrick's Day together. So we're going with the St. Patrick's Day green, or you could do whatever color you want. But if anybody is interested in knowing more about that, just reach out and we'll share that with you in the future. I just didn't want y'all to log on for the PED Symposium and fail to win a door prize, you know, one of those highly coveted Trauma Llama shirts and be so disappointed. So we will have a mechanism if you want to purchase some with your colors, they will honor our pricing for our door prizes. And I think Tracy also mentioned that this is got to be the year that I'm going to, she put it in my goals for my job performance that I've got to give up this chair position this year. So I've been trying now for 5 years and have totally failed. So if anybody is interested, now's your time to come and join in the fun and take on a leadership role. That is not to say, please understand me, that, you know, all of you, you know that I appreciate you and we could not do this stuff without you. And certainly I have felt supported by our team in this role, and just glad to highlight all the work that y'all do. But we just want to make sure that we're passing the torch as we should when that time comes, and that time is going to come this year. Also, Liz mentioned earlier, Greg, I want to thank Liz and Gabby for your wisdom and hiring a RTAC, a Stop the Bleed coordinator to assist with programming throughout the state. I think that's very much needed. Greg does live 2 miles from me, but I don't know that I've ever seen his house. So just saying, Greg, I think, you know, it's worth a barbecue so that everybody can see that. But Greg, some of y'all may not remember, but Greg was actually in the initial, he came up when Dr. Ashley first presented Stop the Bleed to the commission several years ago. And he's the one that taught us that we needed to put tourniquets in plastic bags, because Greg and I spent 3 hours afterwards trying to separate y'all's tourniquets out. Just saying. But anyway, thank y'all all for all that you do. And we're just going to have a great Trauma Awareness Month coming up.
Thanks, Kristen. Okay, Kim?
You guys have,
You have to come to mine. Yeah.
just checking to see if y'all have my slides.
Yeah. Here,
Mind if I join you over here?
you got a clicker over here.
Oh, complicated.
And I can, I don't even know if it works. I'm gonna pull it up real quick.
I mean, I want to drop long shirt. No idea why.
Don't be supposed. Where to go from?
Yeah.
Thank you, guys. It's great to be back here and see so many faces that I haven't seen in a while. It's exciting. Thank you. Welcome. I'd love to meet everybody who's new. Hi to friends on the phone. Good to be in person again. My name is Kim Cotterman. If you don't know me, I'm the Director of Professional Programs and Transplant Center Relations for Lexington, Georgia. And really honored to be a part of this committee.
I'm old and I can't hear.
Thank you. You know, we were brought into this group, gosh, gosh, I guess maybe 10 years ago now, kind of recognizing the piece that donation has to play in the trauma world. First of all, recognize that we are one call that you guys never want to have to make. But when that is the situation, and we appreciate your support in being able to offer that opportunity to families. So I traditionally have come to this meeting a couple of times a year to just sort of give updates on what's going on statewide with LifeLink. And every one of you at each of your hospitals has a hospital development liaison. And so it's their job to keep the program going at your individual institution. So if you don't know who that person is, please reach out to me and I will connect you. Because I hope that you're involved in that program, maybe on a donation committee or involved in some events that I'll show you here in a second. Give this a try. All right. So a couple updates from 2022. Hopefully you know that 2022 we broadened our clinical triggers for making a referral to LifeLink. That is a little bit more of a burden in terms of phone calls that you'll have to make at the time when you have a lot going on. But the idea was really to cast the broadest net to make sure that we're exploring every opportunity for donation, that we're getting involved really with you guys, not necessarily the family, but that we're involved really in the process so that as things evolve, we're ready and available to meet that family where they are and to be able to have those conversations as appropriate. So I'll give you a couple data points here to show you. It's a little hard for me to read this from the slide. But you can see there's 6751 is our total organ referrals on the calendar year, which is up about 800 or 900 from the year before. And most importantly, we had 447 organ donors last year, which is the first time we've ever been over 400. So really tremendous growth. Those triggers are paying off. This is not necessarily an increase in overall deaths or non-deaths for that matter, but just in really effective referrals and making good use of those. I have on the left side, you can see those are overall referrals by mechanism of death. And it's a little bit broken out, so you can see blunt injury and gunshot wound kind of in the middle there. Trauma in general accounts for about 30% of all of our organ donors. It's a little bit smaller percentage, 30 to 35% of our donors, somewhere around 20 to 25% of our referrals. So in terms of those that convert to actual donors, and trauma certainly is a big area for us. Other points to note here, you just see missed organ referrals and trained requesters along that right column. I'm not going to go into any detail about them. Those are metrics that we look at and things that we do review in the donation committee when we need some really process improvement opportunities, things that are great to put in your PI plans and talk to when folks come to visit in their surveys. A couple more calendar year highlights. I don't know how well you guys can see these. I apologize. We can send the slides out. And the stars there are all hospitals that had new benchmark years. And we look at 5-year benchmark. So you can see kind of the largest trauma centers graded 49 organ donors last year. We do also benchmark Memorial 41. First time we were at over 40 there. And then you see Madison, Kingston, AMC, which you won't see next year, unfortunately. And then AU, Northeast Georgia, and Emory. And then again, some kind of going down in size, but Edison, Lynette, and doctors. So I used to do a really detailed breakdown of every hospital, so if you guys remember that, we've gotten away from doing that, and it was really a big data pull, but to look at where the trauma-specific numbers were for every hospital. I hope we've gotten to the point now that you are doing that with your liaisons in the hospital. If you aren't and you need our help, let me know, because we are happy to clean that data. But the challenge that we found is that when you look at this other slide, this is really how we categorize our deaths. And then we have this catchment of other, and we found that when we went through the other, we were really missing some of your traumas and underreporting that in numbers overall. So we've kind of switched to saying, you guys give us your deaths, and we'll tell you which ones we can't donors, because it tends to be a little bit more accurate. It's kind of like whatever the information we get on the phone, we get that call, is the best that we have to work with. And it was a lot of deep data diving and sometimes best guessing. So we thought it was a cleaner way to do that, but happy to help you sort out that data if you can. I want to give a shout out to a couple hospitals, Wellstar, North Fulton, and Memorial. I don't know if you're familiar with this, but about 6 years ago, we started the Barbara John Muir Donate Life Award. And it is an award that we give in partnership with the Georgia Hospital Association every year. We started it in 2017, and Reading Regional was one of our first winners. And then we awarded that year, the CEO of the hospital came to me and said, hey, I have this idea. Would you consider doing an endowment for this award? And so we did, and we renamed it Barbara and John Ware. So just quickly, you can see there John Ware in the photo. He is a kidney recipient, very accomplished, impressive resume, lieutenant colonel in the Army, huge in his community, CEO of companies, on and on. And then his wife Barbara is in the corner there, also super active in the community, lots of boards. She's a teacher. The year before we did this endowment, she suffered a stroke and became an organ donor at North Georgia. And so, I mean, just such an incredibly fitting family to make this, have this award renamed after. So really thankful to our partnership with GCTE to continue to do this. But shout out to Lester and our Colton and Memorial, both have been exceptional years in building their donation programs and really solidifying. Memorial has a kind of cool program now with a texting system that they use for notification whenever there's a case going on to make sure everyone is notified. Wells Fargo Colton has done some things in the last couple of years to really build a way that they honor their families and when they have a donor. So really great work to work with them. Several other hospitals in the room have been winners of the past. So real quickly on the grade book, the new standards, there is a section, it is 2.13, the Oregon Procurement Program. And it's really, there aren't really a whole lot of changes. It's been maybe pared down a little bit from the orange book, but really kind of the same things that it mirrors what they're looking for if you have the DND or Joint Commission on, that you have a partnership with your OPO, that there is a policy for brain death, that you have a place that you are looking at sharing your metrics and working on process improvement. And move over here, make sure I can. I can't read it from there. Okay, yeah, sorry. So the only other thing I wanted to kind of draw attention to is in the PIPS plan, there's all of these metrics, right? And there's a tiny one little line that has to do with organ donation. And it is the referral and organ procurement rates. So again, your liaison can work with you to make sure that you have those rates. They are changing a little bit because some of our metrics are changing about what constitutes a referral and conversion rate, but we're happy to work with you to get those numbers. This is, from the book, this is how they say you calculate the rate, which is donors over referrals times 100, which sounds super simple, right? It's a little bit more complicated than that because it doesn't really define well what constitutes a referral.
And in the current PRQ for the Orange Book, they're asking number of, let's see, number of referrals, number of donors. No, I think it's, oh, I'm getting confused now, but how many referrals you've made, and it should be very close to your number of deaths.
Yeah.
And then how many met organ procurement criteria, and then how many became donors. So it's really important that you capture this in your registry. Unfortunately, this is where we have some ambiguous data fields that are not defined and that do need to be defined. I know at our facility, we kind of got our own facility definition, but we do have some holes in it. So we're working with our hospital liaison to fill that stuff in. And so if for some reason there is documentation that you're not receiving after the organs are harvested, whether it's at your hospital or at the procurement center, then they can get that for you, because that's what I'm doing to follow up.
Yeah, I thought of that when we were talking about the definition earlier. Some of the metrics are a little bit vaguely defined. So
Right.
I'm not sure if some the same. There's also per the CMS regulation, the OPO has to be notified on every death and imminent death. So the imminent deaths are really those potential vascular organ donors, right? Those that are on a ventilator, likely to be brain dead or to be a potential for donation after circulatory death. And then there's the cardiac death referrals. which is any death that occurs. So this definition, and formula here is really looking at those vascular imminent death referrals that go on to become organ donors. It doesn't really account for cardiac deaths and tissue referrals. But great to have a performance improvement plan, and something that they certainly are interested in hearing about when you have your surveys and visits. So again, I'll share my number and my email, and you guys need any help in data definition or interpretation. Just a couple other fun things that are going on that I wanted to let you know about is that those of you who have been involved with the Workplace Partnership for Life, which is engaging hospitals and organizations in promoting organ donation awareness, they give an award every year. It's sponsored by HRSA, and they give awards to hospitals that are involved in the campaign. It has been changed to the donation campaign. And there's a little bit, I'm not going to go into all this history because it sort of doesn't matter, just so that it's been rebranded and that they are continuing, though there is a new cycle out. So if you guys are interested, again, whoever your contact is, there is on the website, again, QR code to grab it if you want. There are scorecards where you can keep track of all of your activities, and then at the end of the period, the awards are sent out by HRSA. And then finally, just April is Donate Life Month, and you guys, most of y'all, I've been involved with really great activities around raising awareness for organ donations. We appreciate everything you do. This year, the theme is Big Splash for National Donate Life Month, with a super cute little frog there. It's usually some sort of garden theme every year with a little list. It was bees last year. Sure, we're gonna do frogs. So, and yes, we do have somebody who has a frog costume. So, if you like a frog, just let us know. There is, as part of Donate Life Month, the Spirit Week. It is April 8th through 14th, and Blue and Green Day is April 14th, which is one of the ones that we really kind of promote universally, that if there's one thing you can get on board with, you can join us for Blue and Green Day, just in your commune to wherever it might be, and encourage people to wear blue and green or decorate. We would love it if you would do that. Take pictures and send it to us. We'll put it up on social media and share it around to spread that awareness. Again, here's the QR code if you want to snag that for how to participate in Donate Life Month. I'll share my contact information in a second. But again, I know there's a lot of new folks, so please, any way that we can use you as a resource. I was just thinking, like, several conversations going on. Jessica told me DMV was just there recently, and they pulled her into a meeting, asked lots of questions about their metrics and how they partner with the OPO, which they have lots of great things to share with us from Georgia, including a journal article that will be publishing soon, which is super exciting. Tracy was mentioning earlier, absent the brain death, virtual brain death project that we have going on. So we're doing some research to try to establish a protocol to be able to do those brain death exams remotely for rural hospitals so that they don't necessarily have to leave their community. And we already know what the outcome is going to be just to get that diagnosis. Sarah and I were talking earlier at Grady about some medical examiner issues and how we can just be clear on the process and make sure that everybody knows how we work through that, because most of our cases are medical examiner cases, and sometimes there's this perception that the ME is going to take jurisdiction and donation can't happen. Not true, but we do have to make sure that we work through the process. So anything like that, anything I can do to help you guys with, please let me know. Any committees here that I can be helpful on, happy to help out. There's your name.
Thank you, Kim. Any questions? Okay, moving right along, we're making good progress. One of the things that Lynn and I are going to do this year is bringing up some of the standards in the gray book, because this is a new year. So you've already heard Kim refer to the gray book standards, or the 22 standards as far as organ donation, and within reason it's the same, but they are asking for a few other things. We want to go over the very first standard in the book. I don't know if any of you have had a chance to look at it, but it's talking about state and regional involvement, something near and dear to all our hearts. So when Gabby sent out the agenda in the minutes, she sent out an attachment. So I don't know if there's anything up there. I don't think so. So you'll have to go along with that, but it's actually just the first. So that's, here we go. So state and regional involvement. So that was the organ procurement, and then we need the other slide. Yep, okay, so we were gonna go over, we as in the Imperial, this training experience is for Lynn, but she is very involved, and our colleagues at the level 3s and 4s always wear a lot of hats. But talk about the things that you need to do, and this is, again, come much to my awareness. I'm blessed that there are a lot of people on staff with me, and we are all involved, but when you're a smaller center, sometimes you have to do more things and be involved in more things. So there's a lot of expectation with trauma centers, and I want you to look at this, because whether it's for the orange book or the gray book, you're going to have to be able to prove that you're involved in some of these things. And so we just wanted to go over this with you.
So you can see in the handout there, the additional information on the standard. We just kind of went through those bullet points and just listed out some examples. So we as program managers and PR coordinators, registrars, everyone can be involved in. So one thing is the RTAC meeting. I'm sure most of us are aware of our regional RTACs, and we're very active in them, but there's some who may not know that the RTAC even exists, especially our new centers. So if the new center contacts you, asking questions, that's a great first resource to send them to. And if they're not sure, if you're not sure on where to find what RTAC you belong to, it's actually on the DPH website. RTAC is on the GTC website. And if I know there are RTAC coordinators, and it actually lists the regions, what region you're in, and it has an email to list that lists the RTAC coordinators. You can get in touch with that person to find out when the meetings are. There's a lot of work that goes on in these, so that's a great resource to have. Second thing we listed was the regional EMS council meetings. Those are usually held quarterly. Those are very informational meetings to attend. To get to know your EMS partners in your region, so you find out what's going on, not only locally in your area, but also regional. They actually have the same issues as we have as hospitals, so it's really good to get to know those folks and get to know what issues they're facing and what you're facing, and it's good collaboration. And the next thing was the Healthcare Coalition. Does anybody attend their Healthcare Coalition meetings? Can you raise your hand if you do? Oh, 2. Well, I'm the regional coordinator for our regional coalition, which is Region H. So this is mainly geared for like disaster preparedness, emergency management. To find out what coalition you belong to, you go to gha911.org, and we have it listed there on the paper, and go to coalition. It'll come up with this pretty little map. It's color coded, and you just find your county you live in, and it will show what region you're in. And then there's a list of all the coordinators and facilitators that you can get a hold of to find out about all their activities. There's a lot that they do. Every year we have a different focus. We just came off peds and burns. So if there's a need that your facility has for equipment or training, if you just contact that coalition facilitator or coordinator, let them know the needs that you have. And if you actually come to their meetings and participate, then they can buy you equipment, supplies, training. We're always doing lots and lots of training pertaining to those. We just did a pediatric burn tabletop drills. How many people have to do tabletops? Especially for trauma centers, we really have to be involved in that. So it's really good. So you don't have to do all the work. You can just piggyback along. But it's really good. One thing that a lot of them do too, every year there's the emergency management group convention in Savannah. And we send at least 20 people out of our region to that. And that's paying for hotel mileage, food, and the cost of the convention, which is, I think, $350 this year. But it's always a great meeting to attend, and the healthcare coalitions, as Kaylee Nadeau always says, it's always based on relationships. You need to know who people are in your region, and not when an emergency happens. You need to know them before, so that way when something does happen, you know who to call or who to text and find out to get that help. So I hope to see all y'all at your next coalition meeting. And then the rest is just some that we just listed. It's pretty self-explanatory.
Also remind you, to follow social media through whatever organization that you're a member of. I don't know that the Trauma Commission or the Trauma Foundation has any social media, do they? But I know our.
Let me talk to my social media specialist.
Okay, yeah, Cheryl. Well, Crystal's our social media specialist for Region 5, but, you know, there are, you know, LifeLink, American Trauma Society, Trauma Centers of America Association, Society of Trauma Nurses, any way that you can support and keep up with what's going on. These are things that you're going to have to be able to prove that you participate in trauma in any way, shape, or form. So we're trying to give you these ideas, but remember when, not if you're surveyed, but when you're surveyed, these are questions you're going to have to answer. So kind of keep up with this, you know, whether you put it on your CV or you have a list of the people at work and what they do and how they do things. I know Liz and Regina have really been pushing people to be more active legislatively, you know, because it's through those sources that we've got money to have meetings like this. Just making sure people know that what's going on. Crystal's done a great job in the whole group injury prevention. They've made it a group project. So they're producing things that, you know, as long as you're a partner in that group, you're doing stuff for your own center. So they're making it turnkey and very easy for you. Also participating in your registry meetings, any of our subcommittee meetings. You can get a lot out of it. You get the support. We have a state that plays in the sandbox together. One day I'll get that t-shirt. But Dr. Joseph is from Arizona. He said they hate each other there. It must be the heat. But we have the humidity and we still like each other. But I appreciate Lynn and what she's presented and brought to the table. I'm excited about this year. I think we have a lot of things going on that, you know, we have a lot to fix, but we have a lot of positives and a lot of strengths as a team. Does anybody want to share anything, any celebrations, experiences, besides the fact that this meeting is almost over and everybody can start heading home? Anybody have anything to share about something going on, coming up?
Tracy, can you hear me and understand me?
Yes.
Had to make sure, not just hear me anymore, hear me and understand me. Lynn failed to mention that she is co-presenting with our team at EMAG. And we're going to be the first day, I think the first breakout sessions. So come to ours, but come with your thinking cap on, because our presentation will be immersive and you will be doing work.
It'll be fun.
Thanks, Crystal.
And there'll be swag.
Yeah, llama shirts.
Oh, llama shirts.
Everything's llama. Yeah.
Yeah, and thank you. I mean, we had 8 hospitals participate in kind of some of our trial runs with this, and we've got 3 or 4 trial runs coming up. So it's growing. It's again, thank all of you for your willingness to step out on faith and just take leaps of faith and be a part of something when you don't understand where we're going sometimes.
Hey Tracy, this was mentioned in the trauma commission meeting. I think a lot of folks have heard it, but as if you don't know, at Northeast Georgia Medical Center, we just recently attempted our level 1 verification to move from a level 2 to a level 1 due to the fact that we have now we have a general surgery residency program, and we are getting to do research and those things needed to be a level 1. And so I did want to share with you guys, we were successful in that visit. We just got our letter like a week and a half ago, and so we're very excited. And a lot of our teams here today, some on the phone, and as all of you in the room know, it's a complete team effort. You know, not just our internal team, but bouncing questions off of this group. And again, I know it's been said multiple times throughout the day, but this is a play in the same sandbox kind of state, and I think that our success is definitely as a result of our ability to, you know, engage our resources across the state, not just within our own team. So thank y'all for your support, and we're very excited, and we'll see what happens next.
I want to recognize Regina and myself before our funeral day. No, that's not what I'm talking. We both have surveys coming up in April. I think there's quite a few surveys coming up this year. John Pope's a new father.
I'm an old father with it.
Well, I was trying to pull those that didn't have the, couldn't see the gray. But you have a
1 month old.
1 month old. Yes.
True, you have to say so.
Yes, and just as a, something for consideration, would there be interest in next year for this meeting? Instead of having this at the end of everything, having it like on the Monday afternoon before our, yeah.
Does that work better? I mean, what, I'm looking at everybody's faces are like,
Yeah.
it's full days. And you have to come in Monday anyway to go to the, I mean, you have to come in
Social.
Monday because it starts so early. You have to come in Monday to party.
Yeah.
But no, I mean, you have to come in Monday anyway because it starts so early on Tuesday unless you're that close. So I feel like if we went back to trying to do this Monday afternoon, and then that way this becomes a half day. And, you know, okay.
2 half days and 1 whole day.
Shaking.
It would help with travel.
Yes.
Yeah.
Yes.
Does anybody hate that idea? Like, does that work terrible for you?
Seeing no nays. No nays. Forever hold your peace. Okay, well, thank you. Anybody else have any other business they want to bring forward? Say anything? Okay, we stand adjourned. Thank you.
Thank you.